All right. Hello, my name's Ethan,
I'm Ben.
I'm Kabir.
and today we have a very special guest, Dr. Beidas. Do you want to go ahead and introduce yourself?
Yeah, hi everyone. My name is Rinad, rhymes with Glad Beidas. I'm a professor and chair of medical social sciences at Northwestern Feinberg School of Medicine.
Yeah, so we're so thankful that we could have you. Your work has been so impressive from the things you've done with implementation science and really all the areas you've covered and all these social issues you're trying to solve. So I want to kind of, before we dive into what we're going to talk about today, which is some of the problems with equity and quality of mental health care and how we can solve them. And I kind of want to dive into your personal story. So as I alluded to, you've worked in many areas, mental health, cancer, firearm safety, and your specialty is behavioral economics and implementation science. So how do those two disciplines lead to what you focus on? Is it kind of more rooted in your passion, or is it more rooted in what behavioral science and or behavioral economics and implementation science correlate well with?
Yeah, that's such a great question. So I think about it with regard to like the mission and the passion that drives me, and then the tools that I use to achieve the kind of mission of the work that our team hopes to do. So when I was young, I remember listening to stories from my father, who's an infectious disease physician. And he was at the front lines of the HIV epidemic in New York City in the early days, and he worked in a safety net hospital. And he told me a lot of stories about patients who had a hard time accessing high quality care in time for their needs. And I really felt outraged by that. I think I was like 10 years old and I was like, this just doesn't make sense to me. Healthcare is a human right. We should all have access to the best quality healthcare and we all deserve to have the best health that we can. And so my mission has really always been about wanting to ensure that and being really committed to this idea that we all deserve to have good health. And then I use the tools of implementation science and behavioral economics to achieve that mission. And so let me tell you what both those areas are, because I am so excited that you all are interested in those two topics, because they're kind of esoteric and not everybody has heard about them. So I'm going to boil it down into like a way that might be easier to understand. So implementation science is all about closing gaps between what we know we should be doing and what we're actually doing in healthcare. So said another way, we really help people and places do the thing, whatever that thing might be, whether it's evidence-based secure firearm storage programs or high quality cancer care. And we have a whole process where we can like go into a setting and ask questions and and kind of act like detectives or consultants to understand what might make it hard or easy to do that thing. And then we deploy solutions or strategies to help. I did that work for about a decade when I began to wonder if we were just kind of always throwing the kitchen sink at in terms of the strategies and solutions. And I was really drawn to behavioral economics because it's all about making the right thing the easy thing to do. And there's a lot of really elegant examples from outside of the work that I do, but I'll give you an example that you all may have experienced. Have you ever been watching Netflix and gone to the next show because the default is that it keeps going unless you stop it?
Hmm.
Yeah, of course.
Yeah.
Okay. That's leveraging a cognitive bias that we have as humans, which is how we think, and called the default bias, right? Where we don't really change defaults generally unless we feel very strongly about them. So I became really interested in this idea of like, how can we make it easier for clinicians who are doing the best they can? No one goes into being a mental health provider or a doctor or a nurse other than wanting to help other people. Like that's why you do that work. And so how do we make their jobs easier and make it, easier for them to deliver best practices? So hopefully that answers your question.
Yeah,
Hmm.
and I think it's kind of interesting because in my brief experience with economics and things like that, taking classes, I feel like economists have kind of an idealized vision of things, and but in practice they're not as applicable or don't work out in the way like behavioral economics. I mean, like there are so many um, there are so many flaws in the way we think about economics, right? But like the classic example of Like if you were going to a concert and it was raining, but you spent $10, you might leave. But if you spent 500, you might stay. That's,
Right.
like some of these
Exactly.
flaws. So I think it's kind of clever. I don't know. And I'll ask you, like, if you had this vision from like a young age that these things go so well together, because economists kind of, think about things in theory, but their implementation doesn't always go the way they plan. So it's kind of a nice mesh of things to make things actually happen and make things actually work.
Mhm.
I definitely did not come out of the womb knowing that I wanted to do implementation science and behavioral economics. Like everything else in my life, it was kind of the result of being in the right place at the right time. So I was mission driven. I knew I wanted to do something that was going to have impact. I started going down this implementation science path. And then I used to be a professor at the University of Pennsylvania. And they have an incredible program led by Kevin Volpe called the Center for Health Incentives and Behavioral Economics. And I started going to their seminars and talking to, faculty and realizing that there was such an opportunity at the intersection. And so that's how it happened. It was a little bit of luck and relationships and being in the right place at the right time.
Mhm. So in terms of like the business side of medicine and like some inequalities, what I think about a lot is like insurance. I think like the business side to medicine is, some people underestimate how much of a thing that is. And my question for you is like, how much does insurance play a role in this, and like in terms of having accessible care to people who maybe are low income versus high income, and how much of a problem is that right now?
Yeah, I mean, I'm guessing we could spend the whole time talking about that. And I don't want to go into all the details around how healthcare is paid for, because first of all, I'm not an economist. And second of all, it would take the whole time. And I know we have a whole set of questions.
Mhm.
But I think of kind of payment or insurance as an outer setting factor. So when we think about how to implement high quality care, there's multi-level factors that are going to drive whether or not we are able to implement effectively. Does the person want it? Does the clinician provide it? Does the leadership of that clinic think it should be provided? And amplifying that, is the payer going to pay for it? So I think of it as kind of an outer setting if you think of a classic social ecological model, and it absolutely drives potentially quality of care and access. And particularly in mental health care, there are a lot of challenges because many mental health providers don't take insurance. And so if you are seeking mental health care and there are limited providers who take insurance or Medicaid or Medicare, then it's going to be really hard to find a provider who can see you without a really long wait list. And I think we've all seen, particularly COVID-19 amplified how much as a world we need mental health prevention and intervention. For a long time there's been this stigma and this separation between mental health and physical health. But the truth of the matter is we can't be whole healthy people if we're not well both in our mind and our body.
Yeah, I mean, just to like speak to Ethan brought up like the insurance thing. We kind of live in an area where there is an abundance of mental health care, I would say, in terms of therapists and centers, some that we've worked with, and they do amazing work, but there's a lot here and not so much in other places that maybe even need it more. But just to give an example, I go to therapy, and I think insurance probably covered much less than 50% of it. I don't know the exact number, but it's therapy is expensive, and insurance obviously. I mean, the problem is that there's such a problem that if all these insurance companies were covering everybody fully who needed therapy, I mean, the premiums would be so high, and that these insurance companies couldn't cover it because the problem is so big right now, and the amount of people who need care is astronomical. And I think you said things amplified by COVID. I think mental health problems were really amplified by COVID. So it's kind of um, gone down the quality. I think the quality of care in a way, and the equity and the equality has gone down over the last couple of years.
Well, I'm really glad to hear that you were able to identify a therapist, and that's really important. I wish for a world where everybody who would like to work with a therapist has that opportunity. I also really envision a world in which we are baking or embedding these kinds of this kind of thinking into where kids are naturally. Right? Like lots of all schools have social SEL programs and are providing support to kids, but not every school, particularly those in under-resourced environments, have access to like a school psychologist or a guidance counselor or an MA level therapist that can provide support to kids. And so one of the things I have thought a lot about, and I don't have an answer for you, so don't ask the question, but maybe you all are the next generation that's going to solve this, is like, and this is no longer a good example because of what's happening in our broader context, but what is the fluoride in water for mental health? How do we think about supporting mental health from a very early age? And I think it even goes back to parenting. Like when I became a parent, I'm a child psychologist. You might think that I would know exactly how to be a parent. I don't. It turns out I didn't. And I'm sure if my kids ever watch that, they will agree. And so thinking about like, how do we support parents in their mental health when, a big change happens in their family, like bringing a baby home? So I wish for a world in which we do a better job embedding mental health support into all of the systems that surround people.
I feel like
Yeah,
mental
there's
health.
like
Oh, you can
oh
go,
sorry.
Kabir. No, you're good.
The conversations you've been having about insurance and COVID-19 really got me thinking about like some of these barriers that exist, like preventing people from accessing quality care. And I was wondering kind of like, have you noticed any like cultural barriers there as well? Like I know we've talked about like insurance, but like as far as like people in different communities trying to seek help, like what are some of the things that prevent certain cultures or certain groups of people from accessing the resources that like people in a community like the North Shore might be more inclined to access?
Yeah, I try not to speak in like broad generalizations, just because I think it's important to think specifically about each community and to know that community well. But I would say broadly, there tends to be stigma around seeking mental health care. I see a generational difference. I see that younger people are more openly talking about seeking therapy and benefiting from therapy. So I'm hopeful that there will be some kind of culture change around that as the next generation of folks kind of talk more openly. But I think for a lot of time, and even in my generation, um, there's stigma. People don't want other people to know that they're seeking therapy. And then, of course, the payment issues, the access issues. One thing that has made it easier, I think, for people to have access to mental health treatment is the revolution that happened during COVID with telehealth. So for example, I don't see clients anymore. I am trained as a psychologist. But when we switched, I was seeing clients during COVID-19, and I primarily see adolescents who have very busy schedules and, are doing things after school and have school. Not having to like travel to my office and just logging in made it a lot easier for some of my clients to see me and not have it take up 2 hours or 3 hours of their day versus the 45 minutes to an hour that we were in session together. So I think there's a number of factors that are shifting. Um, and I have thought for some time that like now is the time for us to really leverage the momentum around what happened in COVID-19 and around people's mental health to make the case that like now is a time as a society where we have to prioritize and invest in mental health research, treatment, services, access, all those things.
And like adding on to like the cultural part, I feel like mental health and therapy is kind of often viewed as like an extra thing. Like, first you should take care of your body and make sure you're fit, and then, the other mental stuff that should, follow that. But I think something that people need to understand is like, everyone can benefit from therapy and having someone to talk to. And I feel like when we start to view it as not like a bonus or extra thing, more
Right.
of like just like going to the gym, talking to someone for even 30 minutes a day can be just as helpful. So yeah, I think that's a good point for the cultural stuff.
So, we were talking about kind of cultural barriers from the perspective of the clients themselves in different communities. Do you view that there's also a barrier in that many therapists are not trained on culturally specific issues that could be causing mental health issues? I remember this
Mm.
year I did a school project about mental health in the Cambodian American community. And one of the main things that they talked about was that as people came from as people came and immigrated from Cambodia, the cultural differences in America were so immense, and it was almost like a shock that carried over generations in that community, especially after they had just experienced the
Mhm.
genocide.
Mhm.
And it kind of talked about how inadequate the care they were getting was, and the investment that was being put into their care was, because the people who were taking care of them and the people in the government who were supposed to be allocating the care were not trained on their specific cultural issues and how they kind of understand their kind of new life in America.
Mhm.
Um, like what are your thoughts on that? What are your thoughts on the barrier from the
Yeah.
therapist's perspective and not the client's perspective?
Yeah, I mean, part of our training as psychologists is to be culturally competent, to have cultural humility, and to take the interventions that we are deploying and to implement them with the light of like context for the individual that we're seeing, right? It's impossible for any one therapist to fully understand all of the context and cultural backgrounds of every single patient that they see or every client that they see. But it is my job to learn from my client about the factors that are important to them. And if I'm working with a particular population and I don't share lived experiences with that population, then the expectation would be that I would really work to understand and learn about what the specific needs are of the folks that I'm working with. One thing that is a problem in the field of psychological science is that many of the interventions that we have developed and tested have not been tested in all communities or with diverse populations. And so, a critique of the field, which is a very fair critique, is that our interventions are not tested with our communities, with all communities or communities we're working with in mind. And so there's been a real movement to move beyond like creating treatments in the academic setting and then trying to push them out into the community to collaborating with community partners to understand what communities need. And then with those partners, developing and testing those interventions in the context with the populations in which they were intended to serve. So I've seen a real shift over the course of my career. I've been doing this about 20 years now, where there's a greater understanding that we really need to be co-creating with communities. So in the example you gave, I would love to see community partners and academic partners developing or adapting and evaluating how the interventions work with that population given their contextual factors.
And like adding on to like, trying to have people specialize in their own communities, my thought is, or my question for you is basically like, if it is a low income community, are some mental health providers a little hesitant to open up maybe like practices there just because of it might not be the best, profit for them? Is there like some challenge with that?
There are definitely different drivers that influence how therapists decide and what setting therapists decide to work in. I was very fortunate when I lived in Philadelphia to work in the public behavioral health system in partnership with the public behavioral health system. And I worked with hundreds of incredibly talented and skilled therapists who worked in the community mental health clinics that were paid for through the public system or through Medicaid. We did do a study kind of looking at turnover in that system, meaning when therapists elected to leave the system. And we did see that when therapists turned over, there were a variety of reasons. Turnover tends to be pretty high in the public system, anywhere from 20 to 40% every year, which when you think about like as a supervisor or manager of a clinic, that means you're like replacing your workforce every couple of years. And that's really hard to kind of do over time. But some of them did go into kind of private practice settings. Some of them went to other clinics within the public system. So I can't directly speak to kind of how people make decisions about what context they want to work in. But I can tell you that I have worked with many incredibly skilled folks who are working in the public behavioral health system and are very mission driven and wanting to make sure that all populations have access to high quality mental health care.
Yeah, that's so. Go ahead. Yeah,
Yeah,
sorry.
yeah. So, thinking about, a clinician's perspective when approaching an underserved community, that kind of inspired me to think about like kind of the policies or laws that currently exist that kind of discourage people from either accessing or giving care to specific communities. Do you think that there are any like current policies or laws that would need to change or should be changed in order to, encourage people to access care or to deliver care? Like just broadly.
That's an interesting question. I have been tracking in the news some evidence that given what's happening right now around undocumented people and immigration, that some people have not been comfortable going to healthcare appointments, for example. So certainly what's happening in the broader context in the world impacts access to care. But I don't have any specific examples from the work that I've done that I could pull in here.
So I wanted to ask just finally before we go into, I guess, the more positive segment of this episode, the solutions. Just something we talk about each episode is social media, because we all view it as a huge, huge driving factor behind the mental health issues we see. I was doing some research yesterday, and the number or the percentage of kids or people aged 18 to 29 that have severe mental health issues is almost double the percentage for higher age groups. And obviously, I mean, one of the main, obviously there are a ton of factors like um, that are that are that are like that are not systemic, but I think one of the new things that this age group is experiencing is social media, and I think it's caused a lot of mental health problems for me. Obviously, Ethan and Kabir, we've all talked about how it's caused problems for us. Just from your perspective and what the people you've dealt with and the solutions you're trying to implement, how has that kind of caused a problem? And maybe on another end, how could it be used to fix the problem?
Yeah, this is still kind of, from my perspective, an open question in psychological science because, Ben, as you pointed out, so much has changed in our world over the past generation, and there's a lot going on. So I don't know that we've been able to directly like see causal links between social media in broad population studies. If you look at the literature, and again, this is not my area, so I'm speaking a little bit out of my area here. You'll find studies that show either way, right? That it is linked with or associated with, that it isn't. And I think last year the National Institute of Mental Health released requests for proposals that were focused on this exact topic. And so my hope is that in the coming years, we'll have a much better psychological science understanding of how social media affects well-being. I can speak as a mom for a moment because I am one. I certainly worry about my kids using social media. And I don't know how you define social media. Like to me, social media is like Instagram, Facebook, Snapchat. Is YouTube social media, or is that just like so it's an interesting generational thing. To me, I don't think of it that way, but it's something I worry a lot about when I see my kids like scrolling through these YouTube shorts and like I see their brain, like I can see their eyes kind of glazing over as they're doing that. I think that the more that we can be together in community, having conversations like this and feeling fulfilling, meaningful connections, the better off we will be as a society and understanding different viewpoints and connecting. There is some really interesting evidence that social media can also be protective for certain subsets of populations, because people can find people like them online in a way that you might not be able to find in your neighborhood. And we do have some
The
faculty.
entire point of, what we're trying to do,
Mhm.
Yeah.
trying to, be able to connect people who are struggling. Right.
Yes, and we do have some faculty actually in our department who do work on getting young people access to treatment at the point of social media when when there might be an indication that someone is struggling. And so I can see it as a delivery mechanism. The fact of the matter is the genie's out of the bottle. Like, do you all think social media is going away anytime soon?
No, definitely not.
Probably not. And so I think then the question becomes, how do we learn how to live with it in a way where it doesn't take over our lives? How do we engage with it healthfully? And how do we leverage it as a tool to get people help if they need it when they're using it?
Yeah. I spent some time researching social media algorithms through this class that I did. And really what we learned is that the entire goal of the social media algorithm and the machine learning models they use is try and figure out what next video they can show you that will elicit the maximum engagement.
Right.
So that's, what are you going to like? What are you going to comment on? What are you going to share? What's going to keep you watching and watching and watching so they can sell ads and increase profit? And really what we found is that the most extreme content that's pushed out elicits the the highest reaction rate. So people want to comment on extreme posts and things that are on both sides of the spectrum
Sure.
that kind of make normalcy and common sense in the middle seem almost outside of the mainstream, and that can really mess with people's minds and cause them to feel ostracized from the group around them that they perceive as normal. So I think that social media algorithms, as they're constructed right now, they're great at making social media companies a ton of profit, as we can obviously see. And I mean, they do a great job of that, but they're not good at actually bringing people together. They're more good at playing to people's emotions and fear and kind of appealing to um people's worst side to keep them on the app. And I think that hopefully people will recognize that in the future and hopefully kind of create solutions for that. So maybe they're more talking to people in their community on these social networking sites
Yeah.
instead of just scrolling and scrolling.
Yeah, I mean, there's no doubt they're designed to keep you engaged. And I feel a lot of hope looking at the three of you that you all will lead social media for good campaigns and or companies. I mean, I think that certainly there is a lot of room for improvement. We may start to see policies that restrict usage in ways that could, protect younger people. I feel that personally, I feel that my kids are not permitted to use social media with the exception of YouTube. And I half the time try to take that away too. So
So I think something, an interesting phenomenon I've kind of seen on social media, maybe not as common anymore, but like a few years ago, I often went on social media. There's a lot of like self-diagnosis. I mean, you see a lot of people like claiming that they have like certain conditions or something like that. And I think that kind of spills over into, so like talking to their friends about like, oh, I'm so OCD. I have this
Yeah.
type of certain conditions. Like, what do you think? What are your thoughts on like this kind of epidemic of self-diagnosis that exists on the internet, like, and how that maybe has been used as kind of like a substitute, like kids talking to each other and like kind of confirming each other's biases about things they have instead of seeking like actual care. Like, do you have any thoughts about that?
Kabir, this really isn't my area. And I don't know if you know this about scientists, but we really try to stay in this space where we have the most knowledge. But what I'll say in response to your question is, I think there's probably, every time there's a topic, there's two sides to every coin, right? In some ways, I think having a space where people can come together and find one another and talk openly about struggles and reduce stigma could be positive, right? For example, as I mentioned, we have some faculty who are working with influencers who are young cancer survivors, and they've developed a whole kind of community partnership model where it's an opportunity for the scientists to share the latest information and for the influencers to help the scientists understand how people want to receive information and that sort of thing. But certainly it can have deleterious effects as you've described as well. And so I'm a person who wants to understand every situation, wants to understand what makes it good, what makes it bad, what makes it easy, what makes it hard, and then find a way to bring people together in a solution-oriented manner to move forward. So I can't say it's inherently good or inherently bad. It is, and it's a phenomenon that's happening. I'd love to understand it better and leverage it for good.
A question I have is, in terms of solutions for mental health care and, your work with implementation science, I kind of am wondering, like, when teens, I feel like some people I know, when they think mental health care, a lot of times they think medication. And I feel like a lot of times, people are like, oh, I can't focus. Like, where can I go get some Adderall? And like things like that gets thrown around a lot. And I guess my question for you is like, do you think there might be more, we need more of that, less of that? Do you think it might become a problem in the future in terms of like implementing like effective healthcare?
Yeah, so I'm digging back into the vault in my mind of the studies that I've seen. I'm pretty sure that psychotropic medication prescribing has gone up over time. I'm a psychologist by training, so I've always been a big proponent of psychological therapy. And I think that we need, a stepped care approach. Like we need prevention baked into all of our environments, into our schools. We need to have targeted programming for kids around how to navigate the world and relationships, et cetera. But then we also need to make sure people have access to psychological therapy. And then some people will need medication. And I think that, and then there's digital mental health tools as well. So there's like a whole ecosystem. And it does often feel like it feels easiest to reach for medication as a solution. But I hope that everybody knows and is aware that there is a wide range of options. And for each particular presenting problem, there might be different evidence-based recommendations. So my area of expertise clinically is pediatric anxiety. And we know that cognitive behavioral therapy is a really effective treatment for anxious young people, and that some anxious young people also need an SSRI, which is a type of psychotropic medication, in addition to cognitive behavioral therapy. And that's really a negotiation and discussion between that young person, their therapist, and also the guardian who's involved in care. So, I think it's really important, especially now as there's more digital mental health solutions, that people understand there's different options and what the pros and cons and evidence are for each of those options.
Yeah, I have kind of one final question before we kind of wrap up and look at the future and what we can do as teenagers. So you mentioned cognitive-based therapy, right? And
Cognitive behavioral therapy, yep.
exactly, and how important and impactful it is. So do you see kind of, and this kind of goes in just to a broader category of like creative solutions that we can implement faster to help people who are struggling and don't have access to care? Are there online approaches or any other creative solutions that can be used with cognitive behavioral therapy? I wrote down that we had a guest on the show, Jason Maratsky, who's a mental health speaker, who said that in a lot of underprivileged communities, in fact, people like talking, believe it or not, to their barbers a lot about mental health.
Yeah, the barbershop model, yep.
How can we use kind of these new technologies and how can we create creative solutions to implement these new technologies that could help people?
I think it comes down to empowering communities and figuring out what each community needs. Because, like, you shared a particular model that might work well in one community, and there may be different models that would be helpful there. And I think one of the things I've thought a lot about is wanting communities to have access to their data. This is me and my science mind, right? Like, You want to know what are the needs. Every community is different, right? What are the needs? Is it anxiety? Is it suicide prevention? What resources are available? And then we have a whole lot of evidence-based programs and approaches that can be implemented, and we know how to implement them. But it has to start with empowering the community, knowing what the problem is, selecting solutions that are going to address those problems, and continuing to collect data so we know that what we're doing helps and makes sense.
Yeah, I don't like asking like what's more important questions because we like we would obviously ideally have both problems solved. But do you think that kind of erasing the stigma and creating awareness about mental health, how prevalent it is, how important it is to seek care, is more important or has to happen first before public or private investment comes in to implement new solutions to help with the problems that exist?
I think they can happen in parallel. I think they have to. And I don't think we can be like, we're just going to wait until we can erase, because people need to see that they can benefit from those solutions and feel better and that it helps their friends and family members. And that will also shift perspective. And I think there's enough need and demand right now that even if there's still stigma, people, if there were solutions, people would access them.
And just one final question. I know you mentioned you worked in Philadelphia through, what was it you said you worked with in Philadelphia?
With the public
Yeah.
behavioral health system. Yeah.
Yeah. So do you view it, obviously there's a lot of public help to, or maybe a lack of public help, but most of the help is public help to help underprivileged areas with mental health. Do you think there's a lack of private investment? And do you think private investment is more sustainable over the future to implement solutions for mental health in these communities?
I think in all communities, we need a mix of diversified funding sources to support public health and mental health and well-being.
So I think now is a good time to kind of ask about your research, what you're doing. What is some good news that you can share? What is some progress that's going on?
Yeah.
What are some statistics that are encouraging? We see a lot of statistics. I'd say 90% of the statistics I see about mental health now are like negative. What is some positivity that's going?
Yeah. So we do work in a lot of different areas, but I'm going to focus this conversation on suicide prevention. And so we have a program of research focused on implementing, closing a no-do gap, helping pediatricians do a brief, secure firearm storage program because we know that 1 in 3 homes in the United States has a firearm. We know that suicide is increasing in the United States for young people. And that about half of suicide attempts are with a firearm. And one of the big problems with suicide attempts by firearm is that it's highly lethal. And we also know that there's room for improvement in how people store their firearms to reduce access or unauthorized access to those firearms at a time when someone might be feeling suicidal. And so over the past decade, we've been working to figure out how to implement this brief secure firearm storage program that we did a lot of adapting with and working with end users, including firearm owners in pediatric primary care. So we just finished this really big trial. It was in Michigan and Colorado. And it was with 30 pediatric primary care practices and over almost 50,000 well child visits. So that's what's so cool about implementation science. The studies are at real scale. And what we were able to show is that we tested 2 different implementation approaches. In one of them, we just created a little bit of a tweak to, when you go see your pediatrician, they have the documentation template that they're putting notes in while they're seeing you. We added to it a little tweak, or your primary care doctor if you're not seeing a pediatrician, where it was a reminder to have a brief conversation about the importance of secure firearm storage and to offer a free lock for the gun in the home. So half of the clinics, 15 of the clinics just got that changed to the EHR template, electronic health record. The other half of the clinics got that changed to the template I just described, and the health system that the clinics were part of provided support to the clinicians and the clinics to figure out how best to solve any problems that came up, like where do you store hundreds of firearm locks that you're going to give to families over the course of a year? And what we found is that really, this doesn't happen at baseline. If you do surveys with clinicians, they'll report that maybe 2% of the time they're having the conversation and giving a lock because it requires the lock to be there. We were able to get it up to almost 50% in the study arm where the clinics got the change to the electronic health record template as well as support to the clinic. So what does that mean? Thousands of well child visits. So like, when kids go for their annual visits included that brief conversation with parents and the offer of a cable lock. Parents took the cable lock. We have some data that's not yet published showing that receiving the program by parent report changed their storage behavior. And we were able to do this in a way that was acceptable to many, many people, and including clinicians and patients of these health systems. And so to me, I am really committed to suicide prevention. We lost a family member to suicide by firearm. That's really what got me in this area. I want to do work that has impact. And I think that study is a really good example of impact and actually potentially saving lives.
I think that's really encouraging to hear. And just a final question, like what is one thing you kind of just want to leave our audience with? We have a lot of Northbrook mom listeners and also just other high schoolers. What's something that just an everyday listener, maybe someone who doesn't have a lot of background in the space, can do to kind of get this mental health thing moving along how it should be?
Can I say two things?
Yeah.
Of course, yes.
Okay. One is a simple check-in with your people, see how they're doing, and get them connected if you're worried. Let's get rid of the stigma. Let's try to make mental health for everyone. And so that's a pretty simple thing that everyone can do. But the other thing is about this current moment. Science, psychological science, is unfortunately under threat right now. Get involved, learn about science. Science is how we continuously improve as a society. Given current threats, funding to learn more about how to implement and develop treatments is at risk, particularly for early career scientists who might just be starting their career. Find your local friendly scientist, learn from them, volunteer or get a job in their labs, and see why this kind of applied social and behavioral science can change lives and contribute to society so that we can all live happy, healthy lives. And I'm really proud that I lead a department where that's our focus, and really committed to making sure that all of our people can continue to thrive and do that work.
That's great. That's great. All right, so I think that kind of wraps up our episode today. Ben, do you have any upcoming things that we want to just quickly shout out?
Yeah, so we're gonna have a bunch of new episodes with new guests featured. We're gonna have therapists on the podcast and many people who run organizations throughout our community to try and highlight their work and break the stigma and raise awareness because, as Dr. Beidas said, it's a very important time right now, and it's a time that we can really either make or break mental health in the future. And we're going to do everything we can to break the stigma. We said it in our New York Times episode. I guess there's some social tax, right? Especially, I would say, in the men's mental health space for, doing a podcast about mental health. But that's okay because, I mean, we get messages about, people we help, and that makes it all worth it. So we're going to do everything we can, and we're going to be having some good episodes coming out. And we had a great episode today. And, I want to thank Dr. Beidas so much for taking the time to make an episode with us. Thank you.
Yes,
Thank
Y'all
you.
are
And-
amazing. Keep up the good work. I'm so inspired by what you're doing.
Thank you.
And just
you.
to end on like kind of a personal note, with all this talk about like mental health, what's something that you do to kind of keep your mental health balanced or just stay grounded in general, like outside of your research? Like maybe listeners can apply that too.
For me, nature really brings me peace and centers me when I'm feeling overwhelmed by what's going on in the world. So I have created a little sanctuary for myself in my front yard with a bird feeder. When you get older, you'll get really into birds. I promise you it's going to happen. It's like a psychological phenomenon. But I have a little hummingbird feeder. And whenever I see the hummingbirds there, or I take a walk outside and look at big trees or the lake, I'm reminded of how big this world is and how many good people there are in it, and how we are stronger in community and in nature.
Perfect. All right. Well, I think that's all for today. My name's Ethan.
I'm Ben.
I'm Kabir.
And just remember, your mind matters.